Welcome, everyone, to the Cleveland Eye and Laser Surgery Center. My name is Dr. David Miller of Retina Associates of Cleveland, and we are going to present a surgical live demonstration of the basics of vitrectomy surgery for retinal detachment repair. We will begin the course with the didactics, some slides discussing the ins and outs of retinal detachment repair using vitrectomy in particular, and then we'll move to the live surgical demonstration right behind me. And then we'll come back and review some more slides and take some questions and answers. We actually have two cases lined up. If we can get through the first one, take some questions, and maybe start the second one, that's kind of the plan for the morning. And next slide. So here we are at the Cleveland Eye and Laser Surgery Center. I'm going to start with the review questions that we'll go over again at the end of the talk. What are the best locations for working sclerotomies in vitrectomy? You can pick your answers now. We'll review them later at the end of the surgery. 3 and 9 o'clock, 3 millimeters posterior to the limbus. 10 and 2 o'clock, 5 millimeters posterior to the limbus. 11 and 1 o'clock, 3 millimeters posterior to the limbus. And 12 and 6 o'clock, 5 millimeters posterior to the limbus. The polling results. We'll go on to the next question. I'll review these again at the end of the talk, at the end of the surgery. What is a possible risk to vitrectomy surgery? Endophthalmitis, retinal detachment, cataract, choroidal hemorrhage, or all of the above? Very good. Go on to the next question. What are the causes of, or possible cause of, vitrectomy retinal detachment repair failure? Proliferative vitreoretinopathy, a missed retinal break, a leaking retinal break, or all of the above? Very good. What criteria are helpful for vitrectomy RD repair? Pick two, pick your favorite two. For the repair to be successful, a superior location of the break, clear media, phakic, or the presence of a PVD, a posterior vitreous detachment. What two of those four would you most like to see as the surgeon going into the case? Okay, very good. Let's go on to the back to the slide. So retinal detachment, just to review briefly for those less familiar, is a separation of the retina from the retinal pigment epithelium. As you can see in this slide here, the retina is detached right through here, right past the macula. You can see where the retina is kind of folded up and has some whiteness to it. You can almost imagine that like wrinkling of a sheet or a drape, whereas here it's flat and smooth against the back of the eye. There's three different main types of retinal detachment: rhegmatogenous, which means from a retinal break, traction, and exudative. We're going to focus on rhegmatogenous, which is the most common form of retinal detachment. So for a rhegmatogenous retinal detachment, there has to be a tear in the retina that allows fluid to dissect from the vitreous cavity to potential space between the retina and the retinal pigment epithelium. No history of trauma or disease is a primary one. A secondary one can be from trauma or some type of disease. And to reoppose the retina or reattach the retina to the back of the eye, we need to get closure of the tear to the back of the eye. This illustrates the fluid of the vitreous cavity up here, coming down through the retinal break, dissecting under the retina, peeling it up off the back of the eye wall. Kind of like wallpaper coming off a wall, or a swimming pool liner coming off the walls of the swimming pool. The fluid gets through the break, and that is the cause of the retinal detachment. So what's a retinal break? Well, there's two main types. There's a retinal tear produced by traction on the retina from a vitreous separation. Most commonly with aging, the vitreous contracts and snaps free, creating a vitreous separation or vitreous detachment. That vitreous detachment then tears the retina. Or there can be a retinal hole produced by gradual thinning or atrophy of the retina. These are more slow developing retinal detachments, also can occur younger in life. You see these most commonly in things with lattice degeneration or retinoschisis. So here's an image of a retinal tear, typically called a horseshoe tear, right? Looks like about like a horseshoe. And this area around here is detached. And over on this side are some atrophic holes within lattice. You can see the little hole here and here. So considerations in case selection for vitrectomy retinal detachment repair. It's important to realize whether the patient is phakic or pseudophakic. With vitrectomy surgery, there's always an increased risk of cataract formation. So there is an advantage if the patient's already pseudophakic. It gives you more freedom of movement in the eye, and also you won't have trouble with the cataract or the lens of the eye causing media opacity, visualization problems. Also, you won't develop a cataract post-operatively. So pseudophakic is a better choice for these types of patients. The view in the media, example, if you have a vitreous hemorrhage, a vitrectomy is a nice technique to repair retinal detachments in the face of vitreous hemorrhage or other vitreous opacities. Again, because to perform scleral buckling, pneumatic retinopexy, or even laser and cryo in the office, much more difficult to do that in an eye that's full of blood. And during a vitrectomy surgery, of course, you take the blood out first and you can see everything quite nicely. Posterior vitreous separation status. So if you're going into a vitrectomy for RD repair, it's going to be an easier case if you already have a posterior vitreous separation. The vitreous can be very adherent, especially in younger people, down around the optic nerve or in the periphery, and that can hinder your case and lower your success. If the vitreous separation is already present, that makes for an easier case. And retinal break location, anterior versus posterior. The more posterior the retinal tears are, the less easy it is to address with scleral buckling, which is another retinal detachment repair technique. So vitrectomy becomes more useful and more posterior break locations. And also superior versus inferior, meaning the top of the eye versus the bottom. Since we're using gas typically in these eyes to tamponade the retinal breaks, any tear that's in the top half of the eye is much easier to tamponade than the ones in the lower half. So ideally, you want retinal tears in a pseudophakic patient with a vitreous separation, with the tears being in the top half of the eye. So the essentials of a vitrectomy for retinal detachment repair include a pre-op evaluation, which is a very thorough exam with identification of retinal tears. You need adequate anesthesia, sterile prep and technique, surgical assistant, ideally, who's familiar with with what you're trying to do during the case. Proper sclerotomy and wound placement. We'll go over that during the surgery. I typically like my wounds down near the horizontals, almost near 3 and 9 o'clock, certainly no higher than 10 and 2, and about 3 millimeters posterior to the limbus. Intraocular visualization, you need to be able to see well, so the cornea or the lens need to be moderately clear. Control any intraocular bleeding, tight wound closure, and post-op evaluation. So what we want to do in the essentials of an RD repair by vitrectomy is a core vitrectomy, take out the vitreous gel in the middle of the eye, make some room in the eye, confirm the location of the retinal breaks. You should have a pretty good idea of where the breaks, the causative breaks are from your pre-op exam in the clinic, but you want to confirm that here in the operating room under scleral depression and some type of visualization, either an indirect ophthalmoscope with scleral depression. In our case, we're going to use a wide field of visualizing system called the IBOS with a scleral depression by myself or my assistant. You want to relieve any traction to the retinal breaks, but that does not mean you have to relieve all the traction. And we'll talk about that during the case. Quite often the vitreous inserts on the anterior part of the retina, tears the retina open, and it doesn't let go on the posterior surface. So you may not be able to relieve all traction, but you have to relieve enough traction that the retina is no longer being tugged or elevated. And then to drain subretinal fluid, there's a posterior or anterior techniques. Posterior, basically, we use a posterior retinotomy, creating a hole in the retina to drain the fluid out. Anterior fluid can be drained through the retinal break itself or by using heavy liquids like perfluorocarbon liquids to push the fluid back up to the top of the eye and drain. Then you need to create a chorial retinal adhesion, either laser by endolaser or cryopexy to create a scar that will seal the tear down so fluid can no longer get through that area. Then you need long-term tamponade, something to plug the hole until the chorial retinal adhesion forms, which can take up to 5 days. So tamponading agents are typically air, gas, or oil. Risk of vitrectomy surgery, of any vitrectomy surgery, includes infection and endophthalmitis, retinal tear, retinal detachment, choroidal effusion or hemorrhage, cataract, glaucoma, especially with the gas tamponades if the mix is wrong, and anesthesia and block related. So here you see us in the pre-op area examining the chart, confirming the eye, discussing with the patient what the surgical plan and goal is. Basic vitrectomy setup with the infusion line down below here, up at the top of the screen, the fluid coming into the eye, the vitreous cutter, taking the vitreous gel out of the eye, and the light pipe so we can have illumination. This is kind of showing the placement of the sclerotomies. This is a cutaway section of the eye, and right here is the iris. This would be the pupil. This is the cornea. So when you come down off the limbus where the cornea hits the sclera, you want to be back at least 2.5 millimeters to avoid all these vascular formations in here, called the pars placata. When you get back in this range, you're in the pars plana, where there's less vascular formation. We're going to try and enter the eye somewhere in this range. I typically go about 3 millimeters back for almost all my cases. Little illustration of how a vitrectomy is performed again. Infusion coming into the eye, light pipe, and the vitrector doing a core vitrectomy. In a phakic patient, this is the lens of the eye. Again, the pupil's up here. This is showing a posterior retinotomy and drainage of subretinal fluid. The retina is detached right here. Okay, the subretinal fluid is the striations. We have a retinal break right here created by the surgeon using an instrument to suck the fluid out through that hole. Once the retina is reattached and flat, probably by putting air in this space, you fill this space with air while you're draining the fluid out of this space. A laser probe is used to seal that retinotomy site. So safety techniques for any vitrectomy, really. You want to confirm intraocular placement of the infusion, maintain intraocular spatial orientation, and control intraocular pressure. You don't want to be too high or too low, and you can see that quite often by either the eye wall infolding if you're too low, or if the pressure is too high, you can see the vascular vessels, you can see them flashing as they're trying to pump blood through those vessels. You want to avoid iatrogenic trauma, retinal tears and cataract being the main ones. You want to check the wound integrity. You want to visualize the periphery at the conclusion of every case, skilled or pressed exam. And you want to give post-op instructions with contact information. Quite often in these types of surgeries with tamponading agents and gas in the eye, you need to instruct the patient and educate them before surgery and after about how they're going to have to hold their head. It can be upright if the tear is way at the top. It can be face down if the tear is near the bottom, left and right side, how they'll sleep and how they'll hold their head during the day and how many minutes per hour. So there's the instructions post-operatively that go over with the patient. Mainly confirming what I do is kind of give them the warning signs of infection. That's the most dangerous thing in terms of trying to recover from. And I also kind of review the post-op positioning instructions with them. How about the results of retinal surgery? Well, the anatomic reattachment, one operation, is about 84% published in most of the literature, with an overall success rate of 90 to 95% if it takes multiple surgeries. In our practice at Retina Associates of Cleveland, our experience done recently and presented at a meeting was 95% with one case success, studied over a 2-year period for 6 different surgeons. So I think the 84% is some of the older literature. I do think newer techniques and newer reviews would have a higher number than that, but I would estimate between 90 and 95% with one case success, certainly is possible. What causes failure? Why would the retina redetach after this surgery? The most common reason is a missed or new retinal break. People always tend to think proliferative vitreoretinopathy is the cause of retinal surgical failure. That is actually not the #1 cause. In my experience, it's more often a break was missed or not adequately treated, leaving it leaking. Sometimes you have poor tamponading or poor head positioning that also can contribute to failure. So here's our first case. Patient #1 is on the table here. We already blocked his eye before the case. He's a 79-year-old gentleman who lost vision for 1 week in the left eye, pseudophakic with a vitreous separation. That's a plus for us here. The vision's 20/70, and the macula is off. Here's his drawing. And the blue is the retinal detachment right through the macula, the bottom half of the macula. And the tear was identified preoperatively superior temporally. There's an OCT here also showing the subretinal fluid just through the macula, which explains why he's still 20/70. So We'll start the case. As any surgery takes, and retinal surgery is certainly no exception. You have to have a team of people with you to perform these cases adequately. So my team here is Julia is my circulating nurse, and Kim is my surgical assistant. Angelica is my anesthetist, and Tennessee Mike is my surgical assistant again. So we'll get it going, and I'll talk through the case, and we can take some questions too. So ideally, these cases run about in time 30 to 45 minutes for a straightforward Rhegmatogenous Retinal Detachment repair. Certainly, cases can be longer, giant retinal tears, multiple tears, vitreous hemorrhage, clear out first. If you have to take the lens out of the eye, all those things can add time and complexity. My partners, I have to thank Dr. Hall for setting our patient up here, Robert, helping us today and volunteering to be in the video. These retinal detachments come in pretty much every day to our practice, but you never know coming off the weekend, and I don't want to get skunked and have no case for you guys. We ended up with about 4 retinal detachments coming through today, so plenty to keep us busy this morning. And the patient's already been blocked. I use a retrobulbar block, very little sedation, and that's about it. And then we prep the betadine being essential for any eye properly draped with the lashes out of the way. You'll notice there's no eyelashes in the field of view because we do consider that a higher risk for endophthalmitis infection. So Mike is giving me the first trocar and cannula, 4 millimeters to the back mark, 3 on this one to the front mark. So the front mark's 3, the back one's 4. And we measure from the limbus. And I tend to put the sclerotomy, I tend to put them all in first at an angle, beveled incision here, pretty much 45 degrees or less, maybe even 30, and just push them all the way in like that. I don't go up and drive in. I want a longer tunnel through the sclera. This leaves the sclerotomies, this leaves the cannulas rather, at an angle where they're almost facing me, as you can see. We also displace the conjunctiva a little bit. You can see how they're facing this way, not straight up. I put the working sclerotomies, like I mentioned, down between 3 and 2 o'clock and 9 and 10 o'clock. Again, with this instrumentation, 25 gauge instrumentation in particular, the instruments are very flexible. And so you don't want to be too high in your site selection because it makes it tough. You have to rotate the eye more. Whereas if I've had the instruments here, I can just pivot to reach the bottom or the back. If I'm down here, I have to drive the eye and the instruments will flex. So now all the cannulas are in with the valves. I'm going to pull this valve off. You got it up there. Sometimes they're a little sticky. We just pop that off. There you go. Turn our irrigation on. Take a look here. We're going to tape that into location there. And then we're going to take a quick look to make sure by looking off to the side and pressing that in that I can see it in the eye, and I can. I doubt that's visible on the microscope. But when you look outside the microscope, looking around to the side, I can see that quite well by pushing it in. Again, always start the vitrectomies with the vitrectomy, the temporal side. We'll put a little Gonac on the eye to keep the cornea lubricated and drop in the wide field visualization system. There we go. Now we're going to get this focused up for you and get you a nice magnified view. I believe, how are we doing there, Mike? Pretty good? I think it's pretty good on the screen. Lawrence, if you think we need more zoom or something, just let me know, of course, during the surgery. The videos come out better with higher zooming than what I normally use. So I just start in the middle here. Quickly, you can identify the retinal detachment, right? Running from superior temporal, down across the macula, down the inferior nasal. The macula is off. It's pretty close to the drawing, is what we saw in the pre-op evaluation. Other information we're gathering here is, one, the blood flow is good in the eye. The vessels aren't flashing. The eye walls are not unfolding. We're maintaining good intraocular pressure. I pretty much have the retractor pedal all the way to the floor for max aspiration. It's a 25 gauge system. I'm starting to move around a little bit. You can see I'm cutting the vitreous back to the skirt, a little enfolding there. So we're gonna let the eye kind of re-inflate. Mike's gonna bump the pressure up for me a little bit. I suspect the bed's high, or the bottle's not high enough. Because I normally don't sit this high. So sometimes when we already developed, one thing we noticed is that the eye wall is unfolding a little bit more than usual. What I didn't check before I sat down was the height of the bed versus where I normally sit in the bottle chamber. And that can affect intraocular pressure. I'm on a Dork machine, the EVA. And though it's a pressurized infusion, bottle height compared to eye height still counts. So we're going around the eye, getting the vitreous skirt out very nicely. And once we got a nice working space in here, we'll talk about things like identifying the retinal breaks, whether to shave the vitreous, get the traction off the tear, etc. All that's coming up. While we're kind of just doing the vitrectomy here, I'm going to ask for an occasional question from Rachel, who maybe can take a look at the list of questions that are submitted or the live Q and answer question answers that are coming in as we're working here by the chat button on the computer. So Rachel, you have any questions? What speed? Gauge. I prefer the 25 gauge. I do pretty much all my retinal surgery on 25, actually all of my retinal surgery on 25 gauge. Why do I like that? Small wounds, no sutures for closing. Instruments are functional enough, even though they're thinner and more flexible. I just like the smaller wounds. I think it's a good instrumentation. So you have a scaled depressor there, Mike? So I'll tend to scaled depress myself when I got the free hand like this. And we'll take a look here. Mike is an expert at helping me out doing this over a decade, and the entire room is really quite expert. We do many, many cases together. Again, it's a nice team approach. And we depress in under a high zoom, looking for the retinal tears. Now, in a pseudophakic patient, quite often these tears can be very small. And so you have to be very patient as you're moving around, dynamic examination like this, looking for any flap that looks like it will pop open and show us the cause of this gentleman's retinal detachment. You do get cases where we cannot find the retinal tear. That's rare. And when that occurs, you end up having to put more laser treatment in than I prefer. I prefer to really just treat the area of the tear. And what we're looking for here, the reason I'm staying in this quadrant so much is you can see the detachment is higher temporally than it is nasally. And typically the retinal tear most often will be located within the first couple of clock hours of the higher side. So it should be, if it's, if the retinal tear knew where it's supposed to be, it should be right in this area. That's where it's supposed to be. And it looks like there's a suspicious spot right there indeed. Right there. Right. You see the little holes right here, everybody? It's going to be really hard. These are tiny. So again, pseudophakic breaks are, Mike, we're going to have to mark this before I lose it. There's a nice angle of it too. Maybe I can get zoom and focus that a little bit for the audience. There you go, right? There's a little dark spot right there. That's our guy. And boy, that ain't much. So it's nice to mark that or treat it with cryo while you're here. And we're going to do that right now. That's just a really thin area, but the tear, I think, is actually this spot. Or that little flap right there even. So what we'll do is what caught my eye was the elevation on the of that right there. So what we're going to do is rearrange my hands here. Give the depressor to Mike. I'll take it in the right. We're going to come back and take a look at that same area, but this time with cautery. Okay. And the point of this is going to be to mark the retinal tear so we can find it later. Let's go a little higher towards me. And of course, everything changes when you move the light to the other side. Right, that's the weak spots. We're going to mark that because we know it's real close to that, basically. Okay, so we give a little cautery burn there, and we kind of know about it's going to be within a millimeter of that all around. We can easily laser that area without having to get more particular. Very good. Now, as far as draining the retinal detachment, I might as well make that retinotomy while I'm here. I'm going to use a posterior drainage retinotomy. We're going to do that. Can you focus the posterior? There you go. So you can see the detachment goes this way. I'm not going to drain in the macula. I don't like to drain too far temporally because it's harder to drain. I like to make my retinotomies more posterior within a few millimeters of the optic nerve. Nasal is always a nice side to drain on. And you're away from the macula again. And so we're going to drain right in here. Make a little cautery burn. So we can pop through the retina there and make a drainage site for ourselves. I'm going to come back and confirm the location of how we mark the retinal break with the scleral depressor. And putting the light back on the other side where I can project the light onto the tear location. Can you focus this, Mike? Yeah, going from posterior, because we're under a higher mag, it kind of throws off the and there's the tear. Again, very subtle, very tiny tear. Right there. Yep, could be a little hemorrhage. We'll get that though too. Certainly. We're getting a little bit of condensation on the eyeballs because I'm so close. So we back it up and let the Mike's going to wipe it for us. But the other way to beat that problem is just to back it up so you're not so close to the cornea. Of course, we're going to continue looking around the eye. There's quite often more than one retinal break. Even in that area alone, I'm suspicious that there's two small ones, not one small one. Down here, we have some chororetinal scarring and paving stone changes. That's not the retinal tears. We're going to check the other side. I'm moving my hands. Rachel, what other question do you have for me? Do you have another one? I'm sure. Right. So tend to run the cutter speeds pretty high when we're shaving and turn the aspiration down to low flow mode. Actually, I use flow more than aspiration. So cutter speed is what, Mike? 7,000. And it's a dual cutting Vitrector. So it's probably higher than that, you know, by how the machine's engineered. And And we're flowing at 7 cc's per minute during the normal case. And oh, shaving is 7 cc's. Yeah, so 15 cc's a minute is normal. And I go down to 7 when we're shaving. I don't tend to shave very much. So this is a common point when I lecture on this and discuss it, is I think shaving is way overblown in terms of importance. That may be heresy to some of you in the audience, but we've been doing this a long time, and shaving didn't even come up until the protectors got to be higher speed and kind of like a machine looking for a purpose a little bit. Shaving then became all the rage. For the most part, those little retinal tears you just saw me cauterize don't have much traction on them at all. And take the return. It's not going to take months to reattach itself. The retina wants to be against the back of the eye. So you don't have to get off every little piece of vitreous around a tear site to make for a successful surgery. And quite often people get themselves into more trouble with things like shaving, creating extra tears, as opposed to helping themselves. My advice would be, you know, if you're not in a PVR type case, you have to wonder how much shaving you really need to do. But certainly I'll take some of the vitreous away from the break sites just to make the laser better. It does have optical effects that can make things more difficult. And if you have an area that's going to take multiple, has significant traction, you can always do this under scleral depression. I think just a large core vitrectomy really will get the job done. Okay, so we only found the one area of the retinal breaks that matches kind of with the expectation of where we expect to see it, near the highest 2 clock hours on the higher side. Created, we're going to drain out the retinal detachment. Again. We're going to drain out the retinal detachment here, apply our laser shortly after that. So the retinotomy is quite often less simple than it looks. So you see the white area, there's lots of blood vessels around it. There always are if you're posterior. And people too often, these retinotomies get away from them. They enlarge and there's bleeding. So we're going to first just engage it to make the hole. See, now I got a hole there from aspirating. I'm just using minimal aspiration. I'm not trying the floor of the petal. I'm probably less than 1/4 of the way down on the petal. Very gentle aspiration. And you always want to know where your reflux is so you can get off the retinotomy. Too often you see surgeons, younger ones in particular, new ones, pull away from the retinotomy site when they're still aspirating, and just the retinotomy just enlarges and runs away from them. So we'll go to air now. You can see the retina is flattened largely already. I was sucking out kind of thick subretinal fluid at the start there. And I'll do that first under fluid. So then I flip over to air. Now here comes the air bubbles. We're just going to drain over the optic nerve until the fluid reaccumulates near that retinotomy site. As the fluid is accumulating posterior, the retina will elevate itself around the retinotomy, giving me a nice pocket of fluid to aspirate again through the retinotomy site. Now you can kind of see it, even like this, even if I take the fluid all the way out of the eye, you can see the detachment still. It's right in here. It's kind of posterior now. There's my retinotomy. I can just go down there and aspirate real gently, pull that subretinal fluid out without stressing the retinotomy site, without getting enlargement. It does happen sometimes, even with being the most cautious that you can. You just have to deal with it. But the goal here is, again, to keep that retina small, keep it tight, and it's one less possible break that could be a problem post-operatively. Letting the fluid kind of reaccumulate here for a minute, maybe 30 seconds, drying it a little bit more. We'll wait again a little bit. Sometimes you get fogging on the back of the IOL. Can you focus that a little bit? You get fogging on the back of the IOL. That is condensation. And we don't have that problem here. You see it only with an open capsule, number one. His capsule is open, but he's not condensing on the back of the IOL. Let's do the temperature differences between the chambers of the eye, posterior to the anterior. And you can deal with it if it's problematic. Either wiping it off with the soft tip. Yeah, it works for maybe a minute or less. I'll take the laser next. Or you can put some viscoelastic on the back of the IOL. That'll always work. So this is a flexible laser, adjustable. Just trying to find my laser pedal. Got the aiming beam on. We're just going to laser down the retinotomy site. So it's just kind of white around the edges. And again, this doesn't have to be done too harsh. But once the stick, you don't have to really, I've maybe had one patient ever redetach from a retinotomy site that wasn't adequately treated. So for the most part, that's all it takes. Small retinotomy. You can see the areas of pigmented lattice down below, some choroidal scarring that near the paving stone. We can go ahead and put a little bit of laser around that. Again, I don't think it's necessary, absolutely necessary to even do this because we didn't find any tears down here. We got a nice, good, clear look. We have good visualization in this case, which is a nice help in terms of being confident. But just in case we missed a tiny break around these weak areas or these thin areas, it never hurts to put a little laser near them. Now we're going to come back and get the tear site, which was temporal. Any questions, Rachel, while we're going through this? Oh, that's a good question. In terms of percentage. Okay, here's our retinotomy site, by the way. Not retina, I'm sorry. Here's our mark, our cautery mark. And we knew we were suspicious of tears right in this area from about here to here. And this optical effect you're getting is from the vitreous base, the insertion right there. And so we're just going to work around that and make this area white with some laser burns. And we're probably going to have Mike depress in this area too because of that optical effect. It makes it a little tough to see how posterior or how good the burns are posterior while we're doing it. So Mike, if you could come up and depress that area, we're going to get a little better view for me and the audience here. Oh, what percentage of the vitreous? So that's good. So he brings out that, he puts that depressor in there. Now the vitreous base ends right or starts right here, but now it's not a problem. And so I think that was that little pigmented spot right there, huh? That could have been the tear site too. And so this way more. And so we probably take out around, 80%, 80 to 90. Again, you don't really need to get all of it. All you're trying to do is get access to the tear and get the tear reopposed. If the vitreous could stay in the eye at even a higher percentage, I'm fine with that, as long as you got enough space for your tamponade, your gas bubble. And the less you're in the eye, the less can go wrong, less iatrogenic type troubles. You don't have to make the case more complex by trying to get more vitreous out. Another question is, am I going to laser all over the place, all the way around, or what? The answer is no. I find that lasering 360, some questions came in, the day before. One of them was, do you laser 360? My answer is almost never, unless there's pathology all the way around, meaning multiple tears, 7, 8, 9, 10 retinal tears, lots of lattice. Then we end up with laser patterns like that. But the real goal is find the break and you'll be fine. I think we're in pretty good shape. So that's about all it's going to take. And we'll drain the fluid. You see the fluid reaccumulated again back here while we were doing that. So we're going to take that fluid out again. And then we're going to put a gas bubble in. I'm going to use C3F8 because the break's just above the horizontal. If it was up higher, maybe SF6, which is shorter acting. I'll use 15% C3F8 gas for this case. Pull the fluid out from over the optic nerve again first, and then go back to the retinotomy site. You can get the gas, Mike, we're good. So Mike, and Julia are going to get the gas prepared. And you can see the retina flatten right back down from that little bit of reaccumulation. I'm a little concerned maybe that the retinotomy site's a little not treated on the posterior edge. Can you have the laser back there, Kim? It's still on, right? So I'm just going to treat the posterior edge there a little better. And not have to worry about it. There you go. Very good. So we're nicely attached. Retinotomy is lasered, some laser down below at the lattice, some laser over at the tear site temporally and superior temporally. And now we're going to swap out the air for the gas. Yeah, so we're going to pull the one sclerotomy site on this side. I'm going to press this sclerotomy site closed with my forceps because there was a bit of a angled incision. So what we're going to do is press on the top of that incision, not at the incision, but on kind of on top of the tunnel to collapse it. And that kind of works. See, the gas stopped. Then we're going to vent through this side as Mike pumps in the new gas, displacing the air from inside the eye. Yep. And so this hole's here, the conjunctiva can be displaced again. Go ahead and pump the eye up a little bit. I'll press against that pressure he's putting on the eye. Very good. I can kind of feel that with my finger. We're in pretty good shape. We're going to pull out the infusion cannula next. And of course, we lost quite a bit of gas there. So we're going to reinflate the eye with the same solution. And I'm going to press this one flat yet too. So little needle here and hooked up to the same syringe of mixed gas. And go ahead. Typically use my finger for intraocular pressure. Keep going, going, keep going. Yep, I gotcha. Probably right there. Keep going. Got a Q-tip there? There you go, you're fine. So now the leak is stopped as the eye pressure. There we go, a little small leak right there. Got a Q-tip. We're going to work on this leak a little bit here, which is kind of nice to show you. So first I use my finger, but we're going to wait a little longer. Quite often the wounds, if they are leaking a little bit, it's actually kind of odd to get the infusion one that's the leaking one. More often it's the working ones. But when you do get a leak like that, you got a 0.12. You can wait just a little bit as the sclera regains its normal shape from elasticity, the hole will close. You can see it used to be a round hole, now it's just a slit. And if we're going to press on it, we're going to press right here over the top of that tunnel. Kind of press that tunnel flat. Get the gas again. A little firmer than I wanted. There you go. Okay, so no leaks. Eyes nicely pressurized. And that concludes the case. So what was interesting in that particular case was a couple of things. One was you had a vitreous separation, you had a pseudophakic patient, that's ideal. The tears were very small. So the toughest thing about being successful in retinal detachment repair is, can you find the retinal break? It's like a game of hide and seek. Those tears can be extremely small, especially in pseudophakic patients. That's as tiny as they get, and I can still find them. So that was a nice challenge to show everybody. But we did find the breaks, and you can use the clues about where it should be and look at those areas more closely. Again, it's usually on the higher side. The detachment was like this, higher on the temporal side, and the breaks are usually within the first 2 clock hours on the higher side. That's exactly where it matched up in this particular case. Also nice to show you that the eye wall infolding at the start of the case. I don't know if that was visible to you, but that was because the bed was high compared to the bottle. Normally I work with the bed lower, but got distracted this morning a little bit with all the videoing. And the other thing that was interesting was the wound leak at the end there. You can see the bubbling going on. But if you're just patient and work with that a little bit, just a little bit, you can do pretty well and not have to get out the sutures and cut down the conjunctiva. So that's all well and good. We got a nice successful case. So I'm very confident him leaving the room. I would expect the chance of that working to being 97, 98%. I'm pretty sure we're in good shape. The one thing about small retinal tears is that the success rate is very high as long as you can find the tear. The bigger tears can have more complications like truly PVR. This should not be a PVR case whatsoever. So to go back to the questions, Lawrence, with the answers and the audience polling, we can kind of go through that, discuss it a little bit. So the review question, where do you like to make the sclerotomies? I would tell you, 3 and 9 at 3 millimeters. All the answers that are 5 millimeters are too far back. You could be into the ora serrata making retinal tears. And 11 and 1 o'clock, I think, are too high. You want to be on the sides where the eye can move really nice. You can flex the instruments and pivot them as opposed to moving the eye. So the possible risk to vitrectomy, the audience was very good with this. It's basically all those are possible risks to vitrectomy surgery, all of the above. So what are the causes of a failure for vitrectomy RD repair? Number 1, missed retinal break. Number 2, proliferative vitreous retinopathy, or number 3, a leaking retinal break. All the above are possible, but missed retinal break is number 1. What criteria are most helpful, in terms of doing a vitrectomy for RD repair? I would say that in terms of success, what you'd like the most is a superior location of the break, because you need less patient cooperation with head positioning. Speaking of, I didn't discuss this, but Mike was already doing it. Robert's position can really be upright during the day, Mike, and then sleep on the, it was his left eye, correct? Sleep on his right side. So we're gonna put him on his right side when he sleeps. The bubble tamponades the temporal breaks. He has a C3F8 bubble. The tears were just above the horizontal. I'll let him stay upright during the day. He doesn't have to be face down. I don't think in this position. That bubble should last plenty long enough to keep those breaks well sealed. You could be, if you're more cautious, put him face down during the day. That's very difficult for older patients, or any patients really. If I was doing face down, it'd be something like 45 or 50 minutes out of 60 during the day, and then still sleep on the right side is probably the number 1 thing. Right side face down. I know the retinotomy is over on the right half, but it's near the optic nerve. It's not far out. So if he's on his right side, it kind of rolls his head down, keeps the bubble in the back of the eye up against the retinotomy, keeps the break high. He should be fine. So as far as my favorite 2 in these answers, I take a superior location of the break and a vitreous detachment being present. Clear media doesn't bother me. Well, clear media, you want that for cornea or a lens, but you can always take the lens. And if it's in the vitreous, you can always be taking out the vitreous. And phakic is never really a help. Phakic is basically a more negative. It's a negative indicator for vitrectomy surgery for retinal detachment repair. The next patient, for those who are going to stick around, 69-year-old gentleman with a recurrent retinal detachment. So he's 1 month post-op. He came in again. Dr. Hall is our partner who found a couple of retinal detachments on Friday and set us up today. So this is a prior MAC-off detachment repaired a month ago by one of my partners. Phakic, 50% gas bubble currently in the eye, 20/80 and the macula is on. This is kind of the teaser, I guess, about whether you want to stay around and see another case. It is different. So the detachment's inferior. Retinal break was identified down here inferior temporally. This is the gas bubble right here, up at the top here, the top half. So this gas bubble is obscuring the vision. The macula is attached, and this is the bottom part here. And the OCT shows you the macula is attached. Yeah, let's do the Q&A while we're kind of hanging out here. Sure. Yeah, how much gas or silicone oil do you inject? Any criteria for that? Yeah, if we were using oil, it'd be great to show you that technique. What we do with the oil is we fill it up to the infusion cannula. So it's just coming back up the infusion line. So it's probably 90%, the posterior segment's probably 90% full with oil. Gas, same, probably more than that, 95%. Yeah, from Michael Mack, how How would you navigate around a trabecular bleb or glaucoma drainage device when placing your trocars? I would stay away from those like the plague. I think any glaucoma devices or glaucoma surgeries can be very dicey in terms of very dangerous to incorporate into your wounds and make for all kinds of problems. So I'll put my wounds anywhere where there's not prior glaucoma surgery. Do you use any pharmacological vitreous detachment prior to surgery? Do I try and induce a PVD prior to surgery? No, I do not. There are medications out there. Thrombogenics had Jetrea, thromboplasmin. There's also just plasmin from the serum. Some people will put gas in the eye trying to induce a PVD. I do not do any of those maneuvers. I just do it mechanically in the operating room. You can get a PVD virtually in every case. Children are the hardest, of course, but you can still get it there by working it mechanically. I'm going to block the patient, I think, Angelica, ready? I'm going to block the patient so they can prep while we do some more questions and answers. And probably you can just spin this a little bit to see. You can watch us working here at the head of the bed. Okay, John, how you doing? Dr. Miller here. We'll do our timeout, okay, working on the right eye. Working on the right eye. Julia's getting it written on the board for us with John's name. And we're doing a vitrectomy for retinal detachment repair right eye. Okay? Look straight up there.
And stay nice and still.
So he just looks right up at the ceiling.
Nice deep breath.
About 1/3 from the lateral canthus. Kind of give the needle a little shake to make sure we're not engaging the globe. Check for any blood return. Then I inject about 5 cc's of this, is it 2% lidocaine? 4%? 2% lidocaine? And 0.75 marcaine. So we got some marcaine and lidocaine. So Julia's, we do cases like this, and sometimes you don't even think too much about the steps that have been the same for many, many years. Not bad, huh, John? We'll get you drapes over your head in a moment, and we'll get the case started. So we're going to go back to the questions and answers and see what we got here. So do you find utility pre-op performing scleral depression to properly identify the breaks, or do you find most with, or you can do it with the indirect ophthalmoscope first? Yeah, I think there is utility in looking in the operating room to find the breaks. You kind of want to know what you're coming into. This case was identified, the prior case where it was hard to identify the breaks, it even had a question mark for my partner, looks like break here, right? So he kind of nailed the area. Dr. Hall has a very good eye. He nailed the spot where the retinal tear was at. But that told me that there was no obvious retinal break. So we're gonna have to struggle maybe to look for that a little bit. Don't like to be surprised. It's always nice to have an idea what you're coming into. Certainly I want to confirm everything in the operating room under the anesthesia, under the more thorough scleral depression. Yeah. Do any systemic diseases lead to retinal detachment? The answer is certainly they do. There's exudative detachments are almost always systemic disease related, posterior scleritis, VKH, etc. Tractional retinal detachments from things like diabetic retinopathy, Rhegmatogenous retinal detachments in genetic conditions, from high myopia to many others, actually. I won't get into them, but that's certainly more rare. How do you control intraocular bleeding? The best rule in intraocular bleeding is not to get any, right? So if you're in a retinal detachment case like the first one, we really don't expect to get intraocular bleeding. We don't want to hit the retina accidentally, cut open a retinal vessel. We do use cautery to create the retinotomy site. Some people do not. I think that can lead to a little more bleeding. You don't want to bounce into the RPE or the choroid, which are vascular rich and can cause bleeding. You can sometimes get unavoidable bleeding just from the wound creation, putting in the trocars. I think the best way to control that is with elevated intraocular pressure and waiting a few minutes. The role of silicone oil in surgery. What is the role of silicone oil in surgery? Silicone oil is nice to use for long-term tamponade, especially in patients who cannot position face down, and for repeat surgeries where there's indications of proliferative vitreoretinopathy. So I try to stay away from oil. I tend to use it for reoperative cases. or patients with breaks inferior that I know they cannot position well and the gas won't be at the bottom of the eye long enough. Prefer not to use oil because you have to come back and get it out. Oil is always a little more complicated. There's always little oil bubbles left behind. It can cause elevated eye pressure. It can emulsify. It can cause a chronic or smoldering uveitis. So I prefer not to use oil. The gas is much nicer. Sometimes I have used oil for people traveling, business trips they cannot avoid or some other function. And if they were flying, oil is tolerated for airplane flights and gas is not. So it does have a role, but I try to stay with the gas. Yeah. Is retinal detachment related to neovascularization? It can be in diabetics. Again, you get neovascularization in diabetic retinopathy, proliferative diabetic retinopathy, and the neovascularization can contract and pull the retina apart and tear it. So it can be. Okay, here's a question, that's all right. Let me just load that. Which is better, an iatrogenic break near the disc, more posterior where the fluid accumulates, or at the anterior retina? So here we're talking about where the retinotomy was created. Do I make a retinotomy down by the optic nerve or in the periphery? And here's the problem. So when you make the retinotomy in the periphery or drain through the original retinal break, you can do that. That's a more skillful procedure. And the talk of the day is the basics of vitrectomy surgery for retinal detachment repair. I think it's much more reproducible if you're not doing many of these cases to make posterior retinotomies and drain posterior. I think draining anterior, which I do in many cases, takes a higher repetition, more skill, and not as reproducible. And you always have some residual fluid that will track down into the macula, and you've got some risk of retinal folds, macular folds. You just want to be a little careful with that. And if you're starting out, I would highly advise posterior retinotomies. I know there's more nerve fiber layer down there, more condensed fibers. You may get a larger scotoma somewhere, perhaps. But if you can keep that retinotomy small, keep it nasal, which projects way out to the temporal field, not anywhere near the macula. I think I've almost never had a patient complain of visual field loss from their what that was. I've never had them complain of visual field loss from their retinotomy site. Am I left-handed? No, I'm right-handed. I'm thinking where that question's coming from. It was a left eye. So yeah, I always start with whichever on the temporal side. So I'll use my left or right hand fairly evenly throughout the case. And I guess I drained left-handed too. I drained the retinotomy site left-handed and I lasered left-handed. Yeah, so you probably saw me going back and forth left and right hand. I'm right-handed. I grew up very strongly right-handed. I couldn't do much left-handed at all. But you want to kind of push yourself as you're doing surgery over the years to use your left hand. Otherwise, maneuvers get much more difficult. It's much simpler to fix a retinal detachment if you can flip your hands back and forth like that. So I would encourage anyone to try and get a little bit ambidextrous if they can. I mean, if I did it, I think anyone can do it, really. So do you aspirate the subretinal fluid? Yes, we did. Once we made the retinal hole there, the retinotomy set, we did use active aspiration. It's hooked up to the Vitrectomy machine. It's a soft silicone tip on there, but I'm using very little aspiration, probably at the most a quarter of the petal being depressed. Does the illumination help find the retinal tear? Absolutely. When you saw struggling to find the retinal tear during the case, what we were doing besides still depressing is I was moving the light pipe in different positions and angles. So you don't want to just be static. You want to be kind of shifting and moving. And I'm a little fidgety anyhow, maybe a little hyper. So I'm always kind of looking, tweaking, and it's a two-handed maneuver. I'm trying to get different angles of light on that area of the retina to get a better view for these tiny tears. Do I use any stains for these cases? Not in this type of case. I do use stains for macular holes and for epiretinal membranes. Typically, I use icy green dye. I have used the blue stain also, but I prefer the green. Let's see. What is the pressure when doing the scleral depression? You know, the scleral depression doesn't take that much pressure. It just enough that you can indent the eye. So it's all by feel and vision. It's more than I do in the office because that would be uncomfortable in the office setting. But here under anesthesia, we can get a better scleral depression, putting the rod against the eye and moving it around. When you make a nasal retinotomy, would it cause a temporal field defect? The answer to that is it does. You can map those out. But again, I've never had a patient be symptomatic from it. Almost never, I should say. But I can't think of the last time someone's complained of it, honestly. Do I always perform a retinotomy? No. Sometimes we will drain through the retinal breaks or put in perfluorocarbon liquids to press the fluid out to the anterior breaks. You can put in these heavier than water fluids and it will press the fluid out. Those can be nice, but the perfluorocarbon fluids, then you have to drain that under air fluid exchange. And it's an oil, and you can leave behind small droplets of oil or something like that. Again, it's an extra step. And for reproducibility, safety, efficiency, and cost, I think very tough to beat a posterior retinotomy, drainage retinotomy. More advanced techniques, certainly there's other ways to do it. We don't use Denzeron heavy oil. We just use perfluoron liquid carbons, and our oil is 1,000 centistroke silicone oil. I prefer that over the 5,000. How are we doing? About set? Okay, so our next patient is set. I'm going to jump to that, and however long the case wants to go. If you guys want to stick around, it's fine. All right, get it going here. This case is a little different, again, because of the recurrent nature of the detachment. Phakic, gas bubble in the eye. So right out of the gate, we're thinking or wondering about whether there's going to be a cataract that's going to obscure our view because of the gas in the eye. The gas in the eye tends to make a cataract develop, or at least posterior feathering, which can make the view difficult. So sometimes we have to frag the lens out. Also, why did the retina redetach, right? The bubble's at half, and we see his retina's coming back off. I did not do his first case, but what we're suspecting is that there's an open retinal break somewhere that as the gas bubble is receding, the break is uncovered. Another possibility would be some early PVR, proliferative vitreoretinopathy in the inferior half of the retina, creating a new break. So we're either going to look for PVR inferior with a new inferior break, or we're going to look for a break that developed or was missed in the first surgery, perhaps. And we'll see. So Mike has the patient again expertly draped and eyelashes out of the way, and the table's a little lower this time. Thank you. And there is our eyeball there. This is a right eye. Very good. So I have to, I'm hesitating. I always pause here when I do this part, you guys, because I don't usually measure much anymore. We kind of just go. But again, anyone starting out, I think measuring is always safe, and prefer not to hit the old wounds, by the way, if I can avoid it. So fortunately, not many people operate on the horizontals, and I'm usually pretty safe down there. There we go. How we doing there? All righty, you're doing fine by our end. We avoid the old wounds, which are typically more commonly higher. But if you know where you go, try to go somewhere a little different. If you hit the old wounds, it just is a little tougher to close the eye. They tend to leak more. Okay. Got to force up there again. So we pull off the valve there. Take a quick look here. It's in the eye. Excellent. Hit that. Put the infusion into the suprachoroidal space. That's always a tougher start, and you have to deal with that then during the surgery. So a couple of things we notice right out of the gate is, one, the lens isn't that bad. He's phakic, but I don't see that much of a cataract. So I think that's a big help. Don't have to worry about fragging the lens. We're going to zoom it in here, see what we got. Okay. You can see the bubble in the eye still. We're going to grab some of that. Some of it already came out. There we go. We just remove the bubble. Don't have to get all of it, just enough so it's not interfering. You see some of the debris flying around from the prior surgery. Where's the detachment? It's running right down here at the bottom. You can see some laser scarring prior up top. And we know the detachment appeared about 1 month out, which tells us there may be a break somewhere at the horizontal or just below the horizontal. Here we're engaging some vitreous already. See the retina kind of coming towards the port. I'll kind of guard the retractor with the light pipe so the retina doesn't accidentally jump into the retractor, and then we got more retinal tears to fix. That can happen. If it does, you just deal with it. You know, whether the retinal tear was made by the vitreous pooling or whether it's made by the retractor. See, we got one right there, an iatrogenic break. I just did that one right there. That's okay. We're looking at I'm looking at the contraction down here. So we can see that the vitreous is definitely not normal. I don't see any fixed folds in the retina. You can see the laser work down here where the retina is very thin. Mike's pointing out this little spot of maybe hemorrhage right there. Let's see if we can find all the retinal breaks. So the vitreous is a little bit stiff. There's a vitreous skirt there that was contracting. We did cut into that inferior to relieve that traction. And again, you get more of that when there's more cryo or laser in the eye. I think one of the reasons I prefer not to laser the eye too much is because, or cryo the eye too much, just because of the rate of PBR seems to be much higher. And so we're using the light again, we're moving the light around, we're looking at this area that was lasered prior. That's pretty suspicious, especially down at the edge right here. And maybe a little attraction from the vitreous. I wouldn't call it PBR, and if it is, it's early, very early. Someone may also ask about, you see the pigment in the vitreous down here though too, right? So I can kind of pull the vitreous a little bit. It is right there. Yep, there's the break. So the causative break is right here under the vitreous. You know, it's right under that pigment. So there's a break basically at 6. We'll get it with the retractor under scleral pressure, but it's right here. And so the technique here that was kind of interesting was to use the light pipe out of the way and see where the retina is going to open up a little bit. And that shows us the break. So it's a tiny break. It's right here. It's not going to take much to reattach that, frankly. Just a few laser shots, okay? And we'll be on our way. So we're going to do this pretty quickly. Let's see, I think you better take the probably you have, give me the cautery. I'll give Mike the depressor. I'm going to take the cautery. We're going to mark that. Okay, it's 6 o'clock. Now we'll do it. Mike, I think you'll be fine right there. And that's our guy right there. Okay, let's go the other way now. Keep going. Where's the one I snagged? Well, we'll switch hands. How about the belt depressor? Now, don't ever be fooled just to only check the bottom half. That's where the retinal detachment is. Sometimes you can get a retinal tear in the top half, and the fluid will drain to the bottom half. And even be more tricky with gas in the eye. Sometimes the break above gets pressed flat during the day, then opens up at night, and fluid accumulates at the bottom. So you always want to look around, even in the clock hours that don't seem like that would be the cause. But this looks pretty clean on the nasal side, for sure. Kenya, you're doing fine. We'll just go to press that and take some of that pigmented vitreous out, Mike. How you doing? Do you have much pain? Okay. Okay. He's having a little discomfort. If he can work his way through it, we'll let it go. If it gets to be more discomforting to him, what we do is we would supplement the block with a subtenon's cut down work. Let's go back to 6 o'clock. So here what we're doing, this is more of like a shave, okay? What we're doing is we're using very little aspiration. And flow. The flow is probably, what's the flow running at there? Do you see it?
It's 4.2.
So 4.2 cc's per minute. That's a very small flow. And we're kind of just working our way down in this vitreous space here, down where that cautery mark is, where we found the tear. Okay, very good. That's all right. So we're going to take out this vitreous below, gives us a little better view. Now, one thing you have to be a little careful or cognizant of, we are risking hitting the lens here too. Trying to hold the retina back. Even at low flow, you can get engagement of the retina. You can come out of there for a second. Just bring the eyebrows over. Yep, because it's hitting on something. There's our guy. That's our other little break right there. So this one ended up being close to this one, but they're not the same. They're just in the same clock hour, ironically. So I was getting down there. So how about I just mark that one too? So this case is not going to be too long. Now the question on this, people would say, oh, hey, should you do a scleral buckle? Should you use oil? I don't think oil is needed. I don't see enough PBR. There was some stiffness in the vitreous for sure, inferior, and we kind of cut that out, but no fixed folds in the retina. Where the drain? Not in the macula, and it's mostly inferior. The nasal is kind of attached right here, so I don't want to go that far nasal. I'd like to stay somewhat posterior. We're going to drain it right here. People sometimes don't like inferior drainage retinotomies, but they work just fine. Certainly higher than the tear site. So the other question is scleral buckle. Would you come back and do a scleral buckle vitrectomy in this case? That's reasonable. What I find is that it's not needed unless there's traction that you can't account for doing the vitrectomy. We go to air.
There's one.
So again, we'll be very gentle at the retinotomy site so it doesn't enlarge on us and get away from us. And in comes the gas bubble. The other choice would be silicone oil at the conclusion of the case over gas. These are small tears. Again, I don't see fixed folds or traction. I'm going to go with gas and spare us having to use the oil and come back and get it. Sometimes, patient fatigue of holding the head down would make me reconsider that, but so you can see the retinotomy enlarged there a little bit as that thick fluid comes out. I'm just chasing the retinotomy down. Sorry for the lighting on that. I should have done a little better job for you guys. The retina is nicely attached. Inferior. Just letting the fluid reaccumulate near the retinotomy site and kind of dabbing up and down, drying it out. Drying it out a little bit more. Then we're going to laser the retinotomy site, laser the tears, and we're set. So we'll take the laser probe. Any questions there, Rachel? Only if there's a macular hole. Well, I should probably rephrase that. Not often. More complex cases with PBR recurrences. Sometimes I'll use the ILM plane to get my PBR up and get it removed. And also in a MAC hole RD case, I'll peel the ILM. It's a little more difficult to peel, of course, in a detached area of detached retina. I think here's the two tears, Mike. 1, 2. So you're going to see us, I can see the tears without scleral depression here quite well. Vitreous has been removed because of the prior kind of shaving under scleral depression. That does make it a little easier to put the laser in this case in the first one. And the other question is going to be how much laser to put in for the prior laser spots, right? With that real thin area of retina. I am going to retreat that area. So certainly those atropic holes are forming in the area of prior laser. That's another problem. If you laser everywhere and you get a redetachment, it's almost like it's moth-eaten, like the retina is almost moth-eaten, and that's not great. And so it's very like Swiss cheese, very holy, so rather not have the extra trouble of having over lasered it the first time around. So we're going to back that up a little bit. Here's the prior laser work. We didn't mark this, but I know that I just want to get around the edges, a little bit over the top, just to give it a little more work, just in case any of these little thin areas got atrophic to the point where there actually breaks from my small holes that could sink our success. Okay. Switch hands here again. Any other questions, Rachel? I'm sure there are. What else you got? Yeah, so the reason there's a recurrent RD in this case, there was a new break near 6 o'clock, or it could have been a missed break. Hard for me to tell if that was new or missed. The vitreous was pooling down there, so that could have been contraction of the vitreous from the first surgery, reaction to the first surgery. But there was a very tiny break, so it's easy to imagine that that was a missed break too. That can happen. And we're just kind of going over this area of treatment that was priorly done. I'm putting a little more laser through it too, but mainly along the edge. Okay, let's dry out the retinotomy site again. Switch hands again. That works a little better on the right. So we're going to dry the retinotomy site. The laser is well done for the retinal breaks down below. And again, as far as where the break was going to be in this case, the retinal detachment was fairly equal left and right. So probably vitrectomized eyes, so the rules are kind of off, but can you focus that for me, Mike? Or losing our view a little bit. Let's see if it looks better under here. Cornea is a little, is it wet? We're lubricated there? Looks pretty good. So there you go. We're gonna get a splash the cornea a little bit. Oh, that worked. We'll dry again at the retinotomy site. Remove the subretinal fluid. Put a little more laser on the posterior margin again. That's typically where we have trouble getting the retinotomy well lasered, where the fluid reaccumulates. And that's it. We use C3F8 for sure. Mike's going to get that for us. And we'll wait for the gas to come over. And I think we're in pretty good shape. Looking at the characteristics of the detachment, the size of the breaks, the amount of what's going on here, I think our chance of success in this case is also very high. I think, John, I think you're going to do very well. Okay, I think it looks really, the case went really well. We're just putting the gas bubble in the eye. And we'll have you hold your head down for the week, looking at your toes, and or reading a book in your lap, or looking at your toes, or a TV, a flat screen TV on the floor will all work. We're going to ask you to hold your head down for about 50 out of 60 minutes. You can pick your head up for about 10 minutes an hour, stretch your neck, eat and drink something. And then when you sleep, I think we're going to use really probably the left or the right side is fine, but face down. So when you sleep, you got to sleep on your left or right side. Let me dry them out one more time. You got to sleep on your left or right side, but we want your nose kind of on the mattress, you know, your face towards the mattress as much as possible. Now, since his breaks are, you know, directly at 6 o'clock more inferior, we do like to leave these patients with as large a gas bubble as we can. And so I go back and dry one last time. That looks really nice and dry. And there's your laser down below. Hang on, I'll get the light pipe going the right way here. There's the laser down below, laser around the old laser work, and then at the retinotomy site. Okay. One thing about how he was detaching, but not all the way up to the gas bubble, it kind of also gives you a clue that the tear was somewhere in the bottom, towards the very bottom. If it was all the way up to the gas bubble, those are the ones more commonly that get exposed when the gas uncovers a tear on its way up. So that tear, that site looks like it's not leaking. We're in good shape. Now we're flipping in the C3F8 gas. I'll hold a Q-tip here. Okay, down to 15. Okay, go ahead. Very good. We need some gas again, just like the last case. And there's our sclerotomy sites. Everything seems to be swelling shut very nicely. We're going to inflate the eye a little bit. Again, to keep a nice firm eye and gas filled. Keep going there. That's good. That's good. So that's kind of the case. So thank you everyone for attending. So glad we could show you these two cases, interesting cases both, always something to learn. The particular things in this case that are interesting is one, there was gas in the eye, but no cataract. Two was prior surgery, so some stiffness in the vitreous from prior, some, I would call it very early PVR, and the cellular vitreous are your clues there. We were able to kind of incise that under scleral depression, did shaving in the bottom half just to relieve the traction. Had an iatrogenic break, a break I created with the vitrector at the start of the case, right near 6 o'clock. And then, of course, the causative break also ended up being near 6 o'clock under the vitreous skirt there. So even when you get a retinal tear like I just did, very recoverable. You just treat it like the rest of the tears. In fact, this one's in the same location as the tear that was causing the detachment, and won't have any bearing on the case. Again, I used a posterior retinotomy. Very reproducible. Back to the optic nerve, the fluid drains back very nicely. You're not struggling with residual fluid and possible retinal folds, or concerns about residual fluid leaving your break open. Large gas fill, C3F8 is adequate. I think oil could have been a choice for this case, but the patient, this looks quite capable of holding his head in the right position, avoid the second surgery, and the scarring process, the PVR process, was very mild. I just don't think the oil is indicated. Scleral buckle would be an option in a case like this too, plus or minus a scleral buckle, but we avoided that. So I think we're in good shape. See you in a bit. So I can go to a few questions and answers. What is this patient's vision prognosis? Very good. He was in here. He was macula off in his first case, like count fingers vision. He recovered with the gas in the eye to about 20/80 with his macula on. I bet we end up with about 20/40 or 20/50 vision when it's all said and done. What are your post-operative medical regimen and follow-up timetable? We'll see almost every patient one day after surgery, patch them up, send it, see him tomorrow, pull the patch off. Then we'll start eye drops, a steroid, and an antibiotic for 3 to 4 weeks. Yes, I did touch my phone and didn't wash my hands again. Wash my hands at the beginning of the day at the sink. And then our protocol here at the surgery center is to use the antiseptic foam that's over to the side. You didn't see me. I hit it both times on the way to the operating theater there. I actually did use the antiseptic foam. Can perfluorine carbon liquids be left in the eye? Yes, you can. I have done that trick quite a few times, especially for giant retinal tears and some other cases. Not often, but enough to say that it works quite well. There are some people who use it almost every giant retinal tear, and can be very helpful. It's a nice reproducible way to repair some tougher detachments. You do have to go back and take it out. I think it's fairly well tolerated in the eye, at least up to a few weeks. What are the indications for vitrectomy and scleral buckle? Really, it's surgeon preference there. If you feel you're getting better success with buckling all your vitrectomy patients, I would tell you to go ahead, and do that. It's more surgical trauma. It lengthens the case. There are more steps involved and risk of complications, perforation of the eye, diplopia, patient discomfort. But if that's giving you a better outcome, I'm certainly all for it. I think if you're doing vitrectomy only for cases like this, the key is you better be able to find the breaks and not leave any uncovered. If you're struggling with that, a scleral buckle will give you some added advantage of closing retinal breaks, even if they're not created with even if they're not lasered or cryoed for a choroidal retinal scar. When do you perform a 360-degree laser retinopexy? As little as possible. I really prefer not to do laser all the way around. One, I think is unnecessary. Two, I think it sets you up for possibly PVR, proliferative vitreoretinopathy. I think the goal is really find the breaks and laser the breaks. But again, if you're having trouble with that and you have to put some extra laser and then increase your success, that's very acceptable. Let's see here. Do you give anything to prevent PVR formation like steroids? No, not really. The medications used to prevent proliferative vitreoretinopathy has been studied many, many years, and And I don't do anything special to prevent it. Even in cases where I'm reoperating patients with PVR, I tend just to remove as much as I can safely. I do use retinotomies and retinectomies and oils and even buckles in those cases, but I do not use post-operative medications in the eye or orally. There is some ongoing work in that. I know it's exciting. There may be some options in the next few years. So what are the options if the primary break wasn't found despite careful inspection? Now, if that happens, I think you're obligated to at least laser the entire area of the retinal detachment. So if the detachment was the inferior half, you're going to probably laser out near the ora serrata, out near the vitreous base for the entire inferior half of the retina, 2 or 3 rows of laser. It doesn't have to be heavy burns. I still make my burns just gray to light burns throughout the region. Typically, those cases go very well because the tears are so small. It doesn't take much. You just got to be close with some laser shots and they'll stick. So I think that about wraps us up. Lawrence, thank you so much, everyone. I know it's been an hour and a half now, a little over. I appreciate the questions. They're all great questions. I hope we could pick up a few pointers to help you out in these cases and try and pick the most reproducible techniques and use them over and over, then advance to other techniques as you get those down would be my advice. So thank you for all the kind words from everyone who's typing in now. And you're all very welcome. I really enjoy it. I hope to see you again soon. Bye.